Hello, my name is Dr. Stephen Harper. On behalf of the STRAC Resuscitation Committee, I'd like to talk to you about pulmonary embolisms today. Now, this presentation is really geared towards our pre-hospital providers and outlying hospitals, the ED staff, internal medicine teams, inpatient medicine, and ICUs, because they're the ones that are dealing with most of the pulmonary embolisms. And we want to make sure that you understand what we're doing on a regional level to make sure that we've got a good system in place to take care of our sickest patients. First, to set the stage, if you have time, I'd recommend watching some of these videos about pulmonary embolism survivors. It'll help set the stage for why this is important. If you don't know what a pulmonary embolism is, just real briefly, a pulmonary embolism is a blood clot in the lungs. It usually forms as a blood clot in the deep venous structures, most commonly the legs, but could be anywhere. It could be in a subclavian vein, jugular vein, hepatic vein. That then breaks off, goes through the superior vena cava or inferior vena cava into the right atrium, into the right ventricle, and out the pulmonary artery until it gets to a place where it becomes lodged in the lung and basically causes an infarction to that section of the lung. It's a pretty significant impact too. There's up to a third of PEs that are untreated, it's estimated, will result in death. And then it's also estimated that about 100,000 people a year die from pulmonary embolism. I think that number might be under-recognized and undercounting people though. I can tell you, treating patients in the field, I've had many that I thought were a pulmonary embolism that we were never really able to figure out if that was the cause of their death or not. But based upon their history and risk factors, it was pretty obvious that that was probably what was going on. So first off, for our pre-hospital providers, how can you figure out that somebody has a pulmonary embolism? This is where symptoms, risk factors, and vital signs are going to be very important. Now, first off, for the heart rate, most likely in a large PE, it's going to be elevated. It's going to be increased. It doesn't always have to do that. There's no one size fits all because PEs can be big or they can be small, that we'll talk about later. But if it's a large PE, generally you're going to have an increased heart rate. Because of what the PE is actually doing, it's causing a VQ mismatch, a ventilation perfusion mismatch. All of these vital signs here, your pulse ox, your end-tidal CO2, and your blood pressure in a large PE are most likely to be decreased. So your oxygen saturation will decrease because of the impaired gas exchange. The end-tidal CO2 will be decreased because you're having that VQ mismatch and you're ventilating areas of the lung that's having no CO2 off-gassed. So by the time you're measuring the CO2, any of the CO2 that is being off-gassed is being diluted by the tissue that's being ventilated, but not having any of that gas exchange. And then, of course, in a large PE, you're going to be decreasing your venous return to the left side of the heart. So decreased blood coming into the left atrium, into the left ventricle, and subsequently a drop in blood pressure. Now, we like to think about terms of risk factor for pulmonary embolism in terms of Virchow's triad. And it's really three groups of things: reduced blood flow, blood vessel injury, and increased coagulability. So all of these things out there are risk factors. And you get one of them, it just kind of increases your risk. You have multiple box checks, and it just further potentiates your risk of having a pulmonary embolism and developing a blood clot. For your symptoms of a pulmonary embolism, first off, maybe they've had DVT symptoms beforehand. That would look like in a lower extremity swelling, potentially pain in the calf or crampy type pain. So if they had those symptoms preceding other symptoms that they had in the thoracic cavity, then that might be a sign that whatever was going on in their leg then broke off and became a pulmonary embolism. The most common symptom of a pulmonary embolism is not chest pain or shortness of breath. It's actually palpitations. And that looks like kind of tachycardia. You're feeling like you have a fast heart rate. You're not really sure why. It doesn't necessarily need to be irregular like AFib, although it could be, but a fast heart rate is the most common symptom. The next most common symptom is shortness of breath, which makes sense because you're having that hypoxia and impaired gas exchange. The third most common symptom is chest pain. This chest pain is usually described as a pleuritic chest pain, meaning it hurts when you take a big deep breath in and feels better if you're kind of like not moving and not taking those big deep breaths in. But it can really be any type of chest pain. I've had pulmonary embolisms that I thought were heart attacks. I've had pulmonary embolisms in the ER that I thought was GERD and ended up being a pulmonary embolism. So keep those in mind. And you can have any variety of these symptoms. It doesn't mean you're not just going to have one isolated symptom. You can have multiple of these symptoms. Less common symptoms, but important ones, are going to be fever, hemoptysis, and syncope. The fever is usually due to inflammation from the pulmonary embolism. Hemoptysis has to deal with basically erosion of blood vessels into the bronchus, and then you start coughing up blood, and this can be sudden onset of hemoptysis as well. It's usually not the hemoptysis that you get from bronchitis, which is like you've been coughing for 2 weeks and coughing up green stuff and now there's blood in it. It's usually you'll just start coughing up blood. And then syncope in a massive PE, because of that sudden drop in blood pressure, it could cause a patient to pass out and have syncope, and that's usually a sign of a really big PE. The EKG in a pulmonary embolism can also be helpful in figuring out what's going on and figuring out how bad it might be. Now, that's not to say that you're always going to have abnormalities on the EKG. In fact, you can have a completely normal EKG and have a pulmonary embolism. If there are abnormalities, the most common abnormality will be sinus tachycardia. On a bigger PE, you'll start interfering with the right side of the heart. Remember, it's backing up blood into that right ventricle and right atrium based upon where that blood clot is. So you might start seeing a right ventricular strain pattern, right bundle branch blocks, right axis deviation, right atrial enlargement. Lots of things on the right side. And then, of course, if you have non-specific ST segment changes, that's always a concerning finding because there's obviously some dysfunction. Speaking of right ventricular strain pattern, this is an EKG that's kind of classic for that. What you see here is across the precordium in V1, V2, V3, you see these big inverted T waves, and that's a sign that the right ventricle is working really hard. The other thing that you'll see is delayed R wave progression on this EKG. Your QRS should be as positive as it is negative, somewhere around V3 or V4. But on this EKG, you can tell that it doesn't completely switch to being more positive until V5. So somewhere in between V4 and V5 is where it's as positive as it is negative. This also has the classic S1Q3 T3 pattern, so an S wave in 1, a Q wave in 3, and an inverted T wave in 3. Now that's not always associated with a pulmonary embolism. You can have that as kind of a normal variant, but it's one of those things that's always classically been associated with a PE. All right, so now you're worried in the pre-hospital environment, you might have a pulmonary embolism. What can you do about it? And the answer is supportive care is the most important thing. Getting an IV, ensuring oxygenation. If they're hypoxic, get them on oxygen. If you need to, CPAP, really maximize that oxygenation, and then continuously monitor this patient. If you have to, and they've got a low blood pressure, you could consider push-dose epi and things like that, some IV fluids. But it's really supportive care directed at what their symptoms are. The most important thing, I think, is people with a small PE, and it's maybe not as obvious what's going on, is consider that as possibly being a diagnosis in somebody with chest pain, shortness of breath, or palpitations, and don't leave them at home. Get them to the hospital so that they can have further studies done. Now, there is some things that help with a pulmonary embolism. This is what's called the pulmonary embolism rule-out criteria. I use this all the time in the emergency room, and there's nothing on here that you don't have access to in the pre-hospital environment. So you could apply it to those patients that seem like they'd probably be kind of low risk for a pulmonary embolism, but you want to make sure that they don't have one. So age, heart rate, oxygen saturation, I think all those kind of make sense. The no hemoptysis, because that's associated with it. No estrogen use, that's a really big one. Estrogen has an increased risk of coagulability and hypercoagulability, so that's something that is on this criteria. And if you're not aware of who's using estrogen mostly, it's in birth control pills. So you got to ask about birth control pills. There are some progesterone-only pills, but if they're on birth control pills, I usually just assume that it has estrogen in it until I find out otherwise. No prior PE or DVT, that's pretty obvious. No unilateral leg swelling, that gets at the DVT symptoms. And then if they don't have any surgery or trauma requiring hospitalization in the prior 4 weeks, then they presumably don't have that risk. However, I go ahead and I throw in that they haven't had any long distance travel in the prior 4 weeks, because that's really talking about immobilization and that risk factor for getting a pulmonary embolism. Now, if they don't satisfy the PERC rule, but PE is still in my differential diagnosis, even if not the highest, I'm obligated to do further testing. So the PERC rule helps rule out PE, but it doesn't rule it in. Just because they don't satisfy the PERC rule doesn't mean that they have a PE. It just means I have to do further investigation, which usually means a CT scan. Once I figure out that somebody has a pulmonary embolism, they really fit into 3 treatment buckets. And this is what we're working on in the STRAC region right now to try to figure out, hey, what guidelines can we give you all to help you deal with these 3 buckets and place your pulmonary embolism patient appropriately into different treatment pathways. The first bucket's green. I made it green because green means they go, and these people can probably go home depending upon if we can get them anticoagulation and we can get everything set up correctly. These are going to be your smaller pulmonary embolisms. On this CT scan, the red arrow is pointing at the clot. It's a small clot. These are usually what's described as a subsegmental or segmental pulmonary embolism. They're not very large, and so they're probably not causing vital sign abnormalities except for maybe some tachycardia. But generally speaking, these patients will be not unstable. If they're unstable, they might have another cause, because that is a small PE, probably not causing a lot of back pressure on that right ventricle. We do have criteria that let us know whether or not we could send these patients potentially home. This is called the Pulmonary Embolism Severity Index, or PESI score. There's 2 versions of it. There's the original PESI score, which is all those ones that say like 10, 20, and 30 points. And then there's a simplified PESI score that's much easier to use, that just has the 1-point scale over on the right-hand side of your screen. Either one of these could be used to help us figure out, hey, what's our risk for sending this patient home? All right, the next bucket is our larger PEs, or our more moderate size PEs. We might call these submassive pulmonary embolisms. On this screen, you'll see the PE on the left pulmonary artery, so that's the right side of your screen, and you'll see that it's pretty significant clot burden there. These next size PEs are going to be our massive PEs. On this CT scan, there's actually bilateral PEs, so both in the right and left pulmonary artery. And you can tell that that right pulmonary artery is dilated, and there's kind of a backup of blood all the way into the right ventricle if we were to look at it on this CT scan. Here's our regional pulmonary embolism guidelines. And we basically put the patients into the 3 buckets: the small, medium, and large, the green, blue, and the red buckets. So the green ones I mentioned can go home, but that's only if you can ensure that you got them the anticoagulation that they'll need to go home on. Otherwise, it's recommended to maybe admit them for a brief observation stay, and then to get them follow-up to make sure that they're getting every treatment option that they need. The next bucket is going to be our submassive PEs. These are going to usually have a little bit elevated right ventricle size compared to the left ventricle. Their troponins might be elevated, their BNPs might be elevated, and we're going to further subdivide these into our low-risk submassive and our high-risk submassive. And that's mostly based upon their vital signs and some of the other tests that we might have done. On both of these, we should consider early consultation with either an intermediate risk center or a high-risk center and transfer to those. If you have a PE response team in your hospital, we really need to be activating them on these pulmonary embolisms to try to get the experts to weigh in and figure out what we should be doing and what treatment options we're going to have. These people might be escalated to needing an intervention rather than just being on anticoagulation. So we really need to watch these patients in the hospital. Our massive PEs are our sickest patients. These are going to be basically your unstable patients, have high oxygen requirements, maybe vasopressors. They might have had that history of syncope or cardiac arrest, elevated lactates. These patients should probably have an ECMO consultation, and in consultation with that ECMO team, figure out, hey, do we need to send ECMO team out there to put them on ECMO and transfer, or can we transfer them to the ECMO center, plus minus giving them TPA to figure out if we need to thrombolyse them before transfer. So talk to your colleagues at the tertiary care referral hospitals that have ECMO capability with our most sick and largest PEs. Now, what to order? Also, you found a PE on your CT scan. You probably got your standard labs and EKG. I'd also consider getting a troponin and a BNP for these patients to see if they're having any evidence of right ventricular strain. For the echocardiogram, if you have anybody that has expertise in doing a cardiac echo, that'll help look for that right ventricle being dilated compared to the left ventricular side. And then don't forget that even if they've got a small PE, it's probably a good idea to do ultrasound in the extremities to look for a clot burden. That small PE might be a sentinel event that kind of lets us know that there's more clot lurking around the corner that could break off. So I would consider doing that ultrasound, and if they do have a significant clot burden, that might not be somebody that you want to send home. Another thing we're working on as the resuscitation committee is coming up with anticoagulation guidelines for our outlying hospitals. Some of the time we're going to be having really sick patients and they might need a critical care transport, but sometimes they might not need that critical care transport, and it might be a long time until we can get it. So we want to figure out what we can do for an anticoagulation strategy. And the answer is we could probably just give a dose of heparin, or we could just give a dose of Lovenox and transfer them without needing to be on a heparin drip. But this is still in draft and isn't finalized yet, so look for this in the future to help guide treatment decisions on patients that we're transferring out. All right, these are our STRAC Regional ECMO Consultation Guidelines. You'll find these usually co-located with the pulmonary embolism guidelines, and it just gives you a further information about when to consult the ECMO team. This is a continuation of those regional ECMO guidelines and the various phone numbers for the hospitals that have ECMO capability. Thank you very much for your time. Feel free to reach out to the STRAC Resuscitation Committee with any questions that you have. In addition, there is one other video that I'd like to direct you to. The video shows a massive pulmonary embolism and a surgical embolectomy, and you'll get to see how utterly huge these pulmonary embolisms actually can be and understand why they can cause such significant illness and unstable patients. Again, thank you very much. Reach out with any questions.